Hi, I'm Matthew Holt, the THCB Spotlight. Hi, with me, Dominique Wells. She is the COO of Conduit Health Partners, and we're going to find out a bit more about what Conduit does in a second. But Dominique, you've been a nurse, an RM working in American healthcare for a while. I won't say how long, but I've read a bit of your stuff about this. And you are now, and for the last few years post-pandemic, have been working in a very specific area, which we're going to find out a bit about, which is to do with transfers and transportation and all the stuff that happens around that, which is probably something that not a lot of people think about in healthcare, but it's probably a screaming big deal. So just give me a quick flavor of your background and how you ended up there.
Yeah, absolutely. Well, first of all, thanks for having me here today, Matthew, and thank you, most importantly, for not disclosing my age through my years of
I don't
experience.
actually know your age, but I read somewhere how long you've been in nursing. So I can
I was
probably
a
work it
baby when I
out.
got started. I was a baby when I got started. But yeah, so my background, I've worked in a variety of roles in nursing leadership. I worked perioperative services for a number of years. And then I got into informatics and nursing informatics and served as the chief nursing information officer for Mercy Health Ohio for a number of years prior to really transitioning into my role here at Conduit almost 6 years ago now. And so, what my passion is having a nursing background, driving and utilizing nursing resources to really maximize care, and using my innovation from a technology perspective to really be able to drive. And so, this has been a really good marriage of those opportunities and that experience that I bring to the table.
Fantastic. So let's get to what is the problem that Conduit is trying to solve?
Yeah, so primarily, when we first got started, we were trying to solve for healthcare access. It's the age-old question, and it's been at the top of minds for many healthcare leaders. And so that was really our primary focus. So what Conduit does is serve as an outsourced partner, and we with a mission to really improve healthcare access. We want to enable resource utilization, so maximize utilization of those RN roles, but also do that through delivering expert guidance, driving robust analytics, and most importantly, really creating collaborative partnerships. So when we work with our client organizations, we're not just a vendor, we're coming to the table and we want to be part of the strategic planning and decision making that's happening within the health system. And our team can do this through a variety of services that we offer. And so the three primary that we do at this point are our centralized transfer center, nurse triage, and patient outreach and engagement services.
All right, so we're going to talk a bit about the first one. We're going to show a bit about the first one in a second or two. People don't think a lot about transport, and for that matter, nurse triage and patient engagement tend to be fairly far down the list when you think about healthcare. But transport is obviously a big deal in
Mhm.
healthcare, and it's probably like the stepchild where people don't think about it, but it occurs a lot and doesn't get the attention it probably deserves. So give me a sense about what does that actually mean? What are you doing? And more importantly, without you, how does it get done now?
Yeah, so that it runs the gamut. So why is it important? There are patients that can show up at a particular facility or location because it's emergent, and they may not have the services, they may not have the capability. The patient may need a higher level of care, and so making sure that we're getting and navigating those patients to the right location to get the care that they need is critical. When we think about how are people doing it today, there are certainly your larger health systems that have internal transfer center systems where they've got people who are facilitating that. We talk to other healthcare leaders where it is a nursing supervisor who's writing it on the back of a napkin and they're trying to keep a manual or Excel spreadsheet, trying to manage as best they can while also manning the house, code situations and overflowing ED and all of those things. And then there are some who aren't doing it at all. And that is that goes to the bedside caregivers to really have to do that. I remember very vividly going into an emergency room. It was a critical access facility, very limited resources, and the ER physician saying, "Listen, I have limited resources, particularly at night, and I might be doing chest compression while holding a phone to my ear and trying to navigate getting this patient where they need to go." And so that's the problem that we're trying to solve. We're trying to lift that burden from those bedside caregivers because they need to be taking care of the patient, and we want to help them be able to facilitate what I call clinic administrative work, really, that's behind the scenes, but that requires to some extent a clinical eye.
All right, we're going to get into the sort of that the what's it like and the how that works in a second. But before we leave the other two parts you mentioned, nurse triage and patient engagement and outreach, what does that look like, and who tends to be using that, and how close is that to the transfer and emergency part?
Yeah, I mean they're separate. I would say outreach and patient engagement and nurse triage really go hand in hand. We're providing that clinical triage support for provider practices after hours. So think about, or even payers or your insurance. So think about having a nurse line on the back of your insurance card and it's Saturday and my provider is not available. You have a resource that you can call and say, hey, XYZ is happening and I'm not sure if I need to go to the emergency room or if this can wait till Monday. So our nurses really help walk through that clinical triage to help the patient have reassurance. I will say most of the time, more than 89% of the time, we're not having to send a patient to the emergency room. We're able to provide self-care. We're able to reassure them and say, you know what, let's get you an appointment for Monday or Tuesday or whenever that is, and be able to give peace of mind when patients are just not feeling well. And the patient outreach and engagement kind of go hand in hand. I'm calling in. I need to change my appointment that I have on Monday because something's come up. And so our team, those two teams really work in tandem to help support patients after hours. We also offer office hour support as well. And just again another access point to get patients through the door and in the right location. We started nurse triage because our parent organization identified that their clinical team, their nurses, were using the emergency room in the middle of the day for non-emergent issues. And so talk about maximum, not overburdening the healthcare system when we're really trying to focus on that. That was our primary priority for standing it up, and we've been able to leverage it for a variety of other roles.
Yeah, we'll probably get on. I read a really amazing article on Kevin MD today about an emergency room nurse not having a great time, and we should talk about that towards the end of the session. But so let's take a look. So it sounds great. We've all seen the ambulances go whiz around the city, and we've seen the life flight hospital, helicopters landing on hospital roofs and whatever on TV. But what actually happens? What's the process if you're replacing somebody writing on a napkin, or an Excel spreadsheet? What is the actual role that Conduit Health Partners comes in and does?
Yeah, so what I brought four of my colleagues with me, and what we want to do is walk through a demonstration of what it's like for a patient request to come in. And so what you're going to see here is the patient, this is a stroke patient who's presenting from a facility that needs to transfer to another higher level of care. And we'll walk through what that process looks like and how our team is coordinating on the back end.
Excellent. So you dragooned some of your colleagues in to come and play actor. So let's go with it.
I love it.
Hello, this is Evan from Lifelight. How can we assist you?
Hi, Evan. This is Liana RN from Conduit Health Partners Transfer Center. I've received an alert for a patient requiring immediate transport from Southampton Medical Center to the cath lab at Maryview Medical Center. His name is Matthew Jackson. Height is 6'1", 195 pounds, and he's 62 years old with a diagnosis of stroke alert requiring an emergent intervention for stroke.
Thank you, Liana. I can confirm that Lifelight will arrive at Southampton with an estimated time of arrival of 20 minutes for transport to Maryview Medical Center.
Very good, thank you.
Happy to help.
Hello, this is Kelsey RN.
Hi, Kelsey. This is Liana RN from Conduit Health Partners. We received an alert regarding patient Matthew Jackson, date of birth 5/20/1963, and we're aware he requires stroke intervention and have set up transport with Lifelight. ETA of 20 minutes to your facility, and you're all set for transfer. Please call 614-555-4444 to provide your nursing report.
Hi, Liana. Thanks for doing this so quickly. We really appreciate it. Would you please repeat back that phone number for report?
No problem. Once again, it's 614-555-4444.
Great. Thanks again.
You're welcome.
Hello, this is Nicole RN, head nurse at Maryview Cath Lab.
Hi, Nicole. This is Liana RN from Conduit Transfer Center. I'm calling to let you know we have a patient en route to your facility with stroke symptoms. Patient's name is Matthew Jackson, date of birth May 20th, 1963, and life flight is en route and expected to arrive at the sending facility within 10 minutes and then back to the target facility in about 30 minutes. They'll be heading straight to the cath lab for a thrombectomy. Is there anything else you need?
No, that's all. We're ready for the patient and getting the team together to meet on the helipad in 20 minutes. Let us know if there's any delay. Thanks for your help coordinating.
No problem, Nicole. It's all about making sure the right care is provided as quickly as possible.
Well, on team, it's like we're back in NAM with the helicopters. Fantastic. Thanks so much. Thanks to all of you for coming and showing us how it works.
Thank you, team.
So, Dominique, that's pretty, self-explanatory, right? There's an alert comes into a facility. How would that alert initially come in? Would that be a different call coming into the Conduit facility, or is there a?
Yeah. So, while we're demonstrating that it's coming in through a call, we have really worked significantly over the last couple of years to try to have other mechanisms or modes of that communication coming through. So the phone is not our primary or preferred source of getting that intake. With some of our client organizations, that initiates by the phone call. But in others, it may come through an order entry where they can order or send in that information. And the beauty of using our telephone system is that order can be queued up for our team to be able to see it just as if a phone call is coming through. Additionally, we try to drive communication because you heard a whole lot of calls. What we want it to be is a single call coming in for the request, and we're saying yes. And then on the back end, all of that magical is happening, and that's the time burdening pieces of the work that caregivers and clinicians at the bedside were doing historically. And so we will leverage things like secure messaging platforms or texting technologies to be able to send a message to a provider, get a quick acceptance. There are some scenarios where our protocols are so streamlined that if it meets certain criteria, we can say yes and just notify Dr. Wells that the patient is coming and that they've been accepted on their behalf.
So in a situation like that, how much pre-work have you done? Presumably you have a contract and agreement with, Lifeline or other transport company. You presumably have routing where somebody, if they're at a critical access hospital which doesn't have a stroke facility, to get them to the local place with a catheter. How much of this stuff is pre-mapped and preordained, and how much is being? So I seem a lot, the poor ER doc with the phone on his ear and doing the chest compressions probably doesn't have this stuff mapped out. So how much of this is sort of background that you've already got these processes done?
Yeah, so that's a great question. As part of our like when we go in to meet with a client organization, we do a deep discovery. So that includes what are the existing contracts that you have from ground and air transportation. We're creating resource materials for our clinicians to have ready access to that information and prioritize contracting. There's all kinds of things that happen in a variety of ways across health systems. So we create those resource materials, but you also have to think about what are the service capabilities at all of these surrounding locations. So when a request comes in for stroke, our nurses have to know really quickly where or which location is going to be a destination location for stroke treatment, orthopedic treatment, cardiac treatment, depending on what service line that patient's coming in. So our team does this deep discovery with the health system using process and protocol and templated documentation for us to be able to intake that. Those resources are then made available to our team. So in the moment, in real time, those resources are able to be managed up for them to be able to know exactly where to send a patient.
All right. So you're taking a lot there off the plate of the people who are in the ER or in the cath lab or, wherever they are in the receiving and the sending facilities. how does this get, and we'll go to the wider issue of nursing and sort of the harassment, well, it's harassment that nurses are under at the moment, but the problems nurses are under. How does this currently get sort of organized and, more importantly, paid for? You're presumably coming out of a budget. Who's paying you? Which of these facilities? How do you guys get paid? I know the ambulance, the air ambulance, and the ground ambulance get paid as well, and there's billing flying backwards and forwards. But who are you going and selling to? Whose budget are you coming out of, and how do you justify this in terms of overall improvement of experience and savings for the health systems?
Yeah, that's a great question. So we contract directly with the health system. So we are working with a specific health system, creating and standing up a line that makes it easy for transfer requests to come through. And so that health system is the one who's accountable for the transfer cases that are coming through. One of the agreements that we have with our client organizations is that there may be times that a request is going to come in and that facility, I say we because we pretend like we are them as a white label. We may not be able to accept that patient for a variety of reasons. They're at capacity, they don't have the service capability at that time, whatever. And what we like to do is what we call final destination placement. And we do that because we want that health system to be the trusted partner. If and when I call you and you help me, regardless of whether you personally can help me or not, that they're able to still, they're going to come back. They're going to keep coming back as a repeat customer. How it gets, the ROI for keeping patients within the health network in and of itself pays for the services. But when you layer on the burden that it's taking and the additional workload that it's taking for those frontline caregivers and folks in the emergency rooms, your nursing supervisors and others, it really frees them up to have additional bandwidth to do some of the other. So all that entire ROI comes out as part of the growth strategy for the health system, retention, prevention of leakage, et cetera, as well as opening and freeing up the resources that they have in the facilities, particularly when we know nursing shortages and other things are a significant pain point for many health systems across the country.
Yeah, and then in a case like the one we just did another little cameo there was, would a critical access hospital that maybe not necessarily be in the catchment area of but calls in or calls in makes that request? I mean, do they have to spend some money on this, or is it all basically the main medical center that's receiving that?
It's the main medical center
that's paying for it. Is there a separate set of billing that they can do via Medicare or elsewhere for this, or are you're basically you have to show that you have an ROI?
That's correct. It's a per case. It's a per case. And I will say that transfer centers have been around for a long time. But what historically it has been focused on those for-profit entities because they understand the growth engine that a transfer center can bring. What we're seeing more and more are your not-for-profits and other entities who are saying, we've got to invest in this in order to A, open access to care, B, make sure that we understand what our market share is and drive patient, acquisition, and be able to take really good care of patients within our communities. So there are a multitude of driving factors that health systems are really kind of pivoting their mindset to say, this is a priority and we have to do this.
It's not just HCA who knows about patient leakage and customer acquisition anymore.
Exactly.
We'll have a separate discussion about where that's all going within American healthcare. Let me widen that a little bit. Two things. First is about Conduit. As you said, you've been around 8 years, which is not that long. I know that your colleague Cheryl, Dr. Norman, started the company with you, and it was like just a few people at the start, and it was around. What happened? Give me about the origin story of the company and how it got.
Yeah, so we originally started as a unit of Mercy Health. Yeah. And so we were originated to really serve and solve a specific problem. So first was access, and that's what they came to Cheryl and said, hey, we need you to help us solve for this. And then the second was nurse triage and really around that employment population. And that's where we really got our start. It wasn't long though after, and it was just by we didn't intend to go out and sell these services. We had health systems coming to us and saying, listen, we've attempted, or it's just a problem and we have to solve it. Can you help us too? And, Matthew, healthcare, as big as it is, it's a small world. And we have a lot of friends that have moved on and been around, moved in different areas and locations. And so when they're calling us, the nature for nurses particularly, we want to help people. And so that was really how we got our start, was being able, word of mouth got out. Hey, you're doing this, you're doing it well. We're seeing really good results or hearing good results around it. And we started to service some additional clients, and then really kept pivoting back and forth to our what I'll call our parent hospital, parent facility, until we then, after COVID, and just really a couple of years ago, put a focus on saying, listen, we can do this and we can help a whole lot more patients. And I always like to tell the story. I had people ask me, as a nurse, how can you leave the bedside and didn't you go into nursing to really take care of patients? And the answer is yes. And I feel like I've had the opportunity to help a whole lot more people, way more people today than I could when I was managing 5 or 6 patients per day at the bedside. And so it's a different type of role, but still being able to make an impact to healthcare delivery.
And what's the ownership structure of Conduit now? Is it still majority owned by Mercy, or what's
Yeah,
who's
so we're actually under HealthSpan Innovations. So
Yeah.
it's an innovative arm out of Secours Mercy Health.
All right, brilliant. That's good. So you're and then what's your scale at the moment? I think you have 230, 40 odd nurses actually, like in the call center, well, at home, and they're all at home, or they're in call centers.
They're all at home.
Where are they, and what's your scale now? Where were you 2 years ago, and where are you going to be in 3 years?
Yeah, so I would say 2 years ago, we were half our size as far as nursing resources. We actually have added 40 or 50 nurses just this year based on, our ability to scale. And again, that total resource pool is used across all of those, transfer center, triage, et cetera. It's spread across both of those business units. So it's not like there's 230 just for transfer center services, but we scale based on the volume and the clients and et cetera. We hope to double in size in the next couple of years and just keep doing that, being able to continue to manage additional volume and help additional health systems.
How many health systems are you working with now, and what's your sense of the kind of share of health systems who've outsourced these things rather than trying to sort of manage it internally?
Yeah, so for transfer center, we're currently servicing 56 facilities. On the triage side, we've got about 56 individual clients that individual practices, payers, et cetera, that we're servicing on the triage side. And our scheduling and outreach, that most of those are for some of the larger health systems that we manage with triage, that just kind of comes along with it.
Yeah, there's 5,000 hospitals and 100 big systems, and 150 big systems in the US. You got some way to go, but I suspect. So let me talk about 2 things to close with. One is, you mentioned your informatics background, right? There is a lot going on, especially where I live in Silicon Valley, of people talking about AI nursing, which a lot of it is taking over things like patient communication, patient engagement, that kind of stuff. But also now this agentic AI of actually doing stuff, and you could argue that you could have an AI nurse that could an AI agent that could take some part of that process and take it over. Where are you in the process of using these new technologies? You mentioned let's get a lot of tech. It wasn't a phone. Let's get a lot of texting involved. Let's put it order entry and drive it down. Obviously, people are talking a lot about agentic AI and doing stuff, but probably not much of it actually happening yet. Give me a sense of what you've looked at, what you've seen, what you're thinking about doing, and where you think this goes.
Yeah, great question. AI is definitely top of mind for us. And I think we still see that there are things that nursing has historically taken on, including in a contact center or call center situation, that doesn't necessarily have to be all portions of that. So like I don't know that I shared this, but in the transfer center, we have some unlicensed resources that are helping manage on the back end activation of life flight. And that doesn't take a nurse to have to do that. And so how do we think about and peel away some of those things and leverage tools like AI, like agentic nurse, other things like that to really think about how we might do that. We certainly know that the appetite from a patient perspective is they want a ripcord. They want to be able to talk to a live nurse. So it's not going to replace nursing or the live people wholly, but there are certainly situations and scenarios for which it might make sense. And so we're exploring all of those opportunities. We're exploring what that might look like. Now, from a transfer center perspective, we certainly see lots of use case. We're using a little bit of AI from like bot technology that's embedded within our telephone system and other things. But as we think about an agentic nurse and a virtual nurse or something like that, we're just in the early stages of really exploring what that's going to look like. And of course, it's going to be an appetite. It's going to, in order for us to adopt something, our clients have to have an appetite for wanting to do that as well. And so, to your point, there's still a ton of conversation. There's still a ton of unknown. And many health systems are dabbling in what that's going to look like. And we're kind of trying to walk right along ahead of them slightly in preparation for their readiness to be able to make some of those moves.
Yeah, I think, probably a live flight situation is not where you want a hallucination. So there's probably going to be some nervousness about that. But you can see a lot of patient engagement and potentially, triage and other stuff where you could certainly start there. And it already has, that's already going on. It's just a question of how wide this gets. Let me ask you about something more general about nursing. Given I have you here and you have the experience, there's essentially since the pandemic, it seems to me that there was incredible pressure on all clinical professionals, especially nurses, during the pandemic. You had this crazy situation during and after where you have half the nurses being travel nurses, and but also the average age of nursing has been rising. You've had trouble recruiting young nurses. There's this big nursing shortage. And things like violence against staff and nurses in the ER and elsewhere in the hospital has been on the rise. I just read an article on Kevin MD about somebody who'd been assaulted 4 times, during their career as a nurse in the ER, and that kind of stuff going on. Where do you think nursing as a profession is? What kind of place is it in? And assuming, well, let me start with that question.
Yeah, I mean, I think there are two sides of the camp. And I think for the most part, for those of us who have been in nursing for a long time and been around the block, I think we're seeing this as an opportunity for us to maximize what we can do and bring a highlight to the work that we bring to the table and how we can change the healthcare model in some ways. So I think that's been a benefit, right? So that's really elevating and saying, hey, we also have a shortage of providers. And so how do we make sure that we still can provide the care that we need to our patients and leverage a variety of resources to be able to do that, including nursing. And so maximizing nursing to the top of their license has really been a positive benefit that's come out of it. Agreed that, I think we are fortunate because we are a remote nursing setting that that we've got a strong pipeline of nurses who are saying, hey, we want to come work for you. We have to balance that with the fact that it's not easy. So you heard that example of that call. This can be a high intensity, high adrenaline, high chaotic situation at times. And so making sure that we're realistic about what that means for nursing and what that transition might look like is important. That's something that's top of mind for us and that we have to pay special attention to as we're bringing resources on and helping them understand what does it really mean to be a telephonic nurse, because it might sound easy on paper, but in the reality of it, it still is high. And it's like operating an ED. It's like being in the ED. You're just physically removed. Benefit, value, you talked about violence. We don't have that. We might have verbal abuse, but we're not really hearing that from patients' perspective, necessarily, because in the transfer center side, we're not really talking to the patients. But those are all things that come to mind as I think about pre-COVID and then post-pandemic and where nursing is. And then I think the other thing is that we're seeing, I've been around and been with I've been in the same position for a long time, not position, but place, right? That's not so movement, nursing movement is really a thing that we have to navigate as well. And think about the length of service isn't quite as long as what we have historically expected or seen.
Do you think that more, I mean, there seem to be more and more roles, and some of them are talking about AI taking over, but there seem to be more and more roles outside of actually direct patient care in hospitals or in clinics. That seems to be more attractive, to some nurses. Do you think we're in a situation where we're in trouble in terms of recruiting to actually do the hands-on patient care? Or do you think that the system will manage to use other technologies and whatever to sort that kind of thing out?
I mean, I think it's certainly something we have to pay attention to and be concerned about, for sure. Particularly, and nursing is so broad. And just hearing my story and all of the doors that I've had open and the experiences that I've had over my 30-year career, there's a lot and it's growing. So there's more. So it's something that we have to pay attention to. Do I think that we have to be worried about it? Absolutely. We're going to have to continue to think about how do we make it attractive to be able to be boots on the ground in the hospitals, in the four walls. But we also know that healthcare models are changing too. So really moving towards outside of those four walls and trying to shift that paradigm is something to pay attention to. And you got to be able to move with that as well. So it's I think it's going to be fluid, and I think it's always been a thing that we've had to pay attention to, and I don't think that that's going to change in the foreseeable future. We're just going to have to continue to be innovative in how we approach nursing and nursing roles and the types of things. I can remember early in my career, nursing just did it. Like if there was a task that needed to be done, nursing would do it because we knew it would happen. And some of those things are going to have to be sparsed out a little bit so that we're making sure that we're giving and reserving the things that we need nurses to be doing for those particular tasks.
Absolutely. I think, that's the whole thing is people reimagine how healthcare is delivered, how the hospital exists, how it works with clinics, and all the information transfer that you guys are a part of that has, actually much wider ranging, wider ranging parts all the way down to sort of, people collecting data and trying to build new clinics online, all that kind of stuff. We're really going to have to reimagine that and reimagine the profession. I do feel that, from what I can see, there has been a massive burden placed on all clinical professionals since the pandemic, and I don't think the rest of America is quite understanding what it's done to nursing and to physicians. And fingers crossed that things will at least stabilize a bit and get better. But I'm worried. But I like what you're saying, right? If you can pass out pieces and make it easier and make their jobs more understandable, closer to the top of their license. That should improve the experience and getting out that sort of scut work. And the vision you gave me of the poor doctor or the charge nurse doing the compressions while they're on the phone trying to find an ambulance is one you don't want to see. Right?
Exactly. I mean, I try to put myself, and we say this to our team all the time. Picture that every call that comes in is your mom or your grandma or your grandpa. Every patient that's coming through. And so when I look and see those kinds of scenarios, that's what we don't want to happen. We don't want that to be our parent or our spouse or our loved one who is on the receiving end of that. And we know that healthcare in general is difficult to navigate already. And any way that we can do to make that easier, more seamless, and get patients where they need is really our priority.
Fantastic. My dogs decided that they enjoy what you said as well. Right. I've been speaking to Dominique Wells. She's the COO of Conduit Health Partners, telling us a lot about their role in nurse triage, patient engagement, and that little skit on how they do transfer. Dominique, thanks for telling us about your company. Thanks for your time.
Thank you so much, Matthew.